me just work on sharing here. So holler up if you guys can't see that slide. I know I always seem to have trouble with the schools, but I think we all have different. Is there anyone who can't see that?
I can see it, Dr. Morris.
Okay. All right. So I know not everyone on here works CD, so I apologize for those of you who have to sit through this. I had given a talk like this a few years ago, but it's good review because some things are a little bit different, but just a good review for everyone who's new or those who may not do TB work very often. We're going to talk mostly about how to handle a new positive TB test or someone who needs a TB test and kind of work it through towards the diagnosis of LTBI. Not really going to talk much about active TB today, but we'll work through this and then we'll take any questions at the end. All right. So basically the scenarios that you guys would most likely face would be someone who is sent to us because they have already tested positive with either a skin test or a positive IGRA or blood test. Someone who's sent to us because they need to be tested for TB. Less likely, very uncommonly, but this has happened, is someone who's sent to us because they have hemoptysis or symptoms of TB and nothing has been done yet, but they're sent to us to be evaluated. So again, I only remember that happening maybe once or twice, and I think it was in a different health department than yours, but that can happen. We hope it doesn't, but just as an FYI. So if someone is sent to us who's already tested positive, first and foremost, you want to just make sure that they don't have symptoms of active TB. So if someone does have symptoms, we need to act really quickly. So we'll get more into the specifics of things here in a minute, but just real quickly, just make sure, hey, have you been feeling okay? And if they say, no, I've been sick, you want to really evaluate them quickly. And if they do have symptoms of active TB, you need to call me. We need to get things moving quickly. If someone is sent to you to be tested for TB, the skin test is not always the optimum way to test them. We can order the IGRA blood test if that is a better method. It just kind of depends on what is best. And so we'll go through that. So there's two ways to test for TB infection. So we're talking infection, not disease. Disease is active TB. So TB infection, the testing is indirect. So we're not actually testing for the bacteria itself, but we're testing for signs that our immune system has already been sensitized to Mycobacterium tuberculosis, or in some cases, some other kind of Mycobacterium. So signs that we've already been exposed, essentially. We can either do the interferon gamma releasing assays, which are IGRAs, and that's the name of the test type. There's two specific brand names, which we'll talk about in a second, or you can do the tuberculin skin test, which is called a TST. We used to call it a PPD, which is purified protein derivative. That's the name of the actual substance you use for a skin test. We don't really call it that anymore because it's not technically correct. So TST is the more correct thing to call it. Really now in the diagnostic guidelines, the IGRA blood test is really the more preferred test, but the TST is acceptable in most situations. So comparing the two tests, the IGRA test is in vitro, takes place in test tubes, where the TST is in vivo, takes place in our body. The IGRA test is more specific. It requires a blood test. We'll talk about it more in a second, but it detects a more specific type of immune reaction than the TST does. It can be boosted if you got a TST test and then an IGRA test. For some individuals, they see that as an issue, but in reality, it's kind of like getting a two-step TST. If you had a TST test and then got an IGRA blood test and the IGRA is positive, Again, people worry, oh, that's just because they got a TST. Well, the only way an IGRA test could be boosted is if you have been exposed to TB before. So again, kind of like a two-step. It'll only be boosted if you've been infected. So, again, it's really not a false positive. It's just boosting what you've already been infected with. The IGRA takes fewer medical visits. So if you have issues or concerns about someone not following up, that can be a benefit. It's not subject to different criteria. I know we are all trained very well to do TSTs, but I'm sure you've experienced times where you question how well a TST was placed by a community provider or how well it's been read, whereas an IGRA is pretty, for the most part, positive or negative and has pretty fixed criteria. Usually you get your results much quicker. It's not affected by the BCG vaccine or most other environmental bacteria. And the results are in EMRs, which makes a difference. A lot of times we'll get people that say, well, I got a skin test. Well, usually those records aren't as easily obtainable as an IGRA test. So again, the IGRA is the name of the test type. There's two commercially available tests right now, the T-Spot and the QuantiFERON Gold test. They work a little different ways, but have the same general principle. They use an antigen or a TB protein that triggers T cells that have been sensitized already to someone who's been infected with TB to release interferon gamma, which is a cytokine that's produced by T cells during an immune response. Cytokines are a hormone-like protein that help with communication during an immune response. So basically, they take your T cells, they expose them to TB antigens, and if you've already been sensitized, then they'll pump out interferon gamma and they measure that response. The antigens that are used in this test are pretty specific for Mycobacterium tuberculosis. Excuse me. There is cross-reaction with 3 environmental mycobacterium, Mycobacteria marinum, Kansasii, I can't pronounce all these, Gordonei and Solgay. Those are not very common at all, but just to be aware that there are a few cross-reactions that can occur with IGRA testing, but thankfully not Mycobacterium avium and not BCG. It can cross-react with Mycobacterium bovis, but that is part of the MTB complex and does cause human disease, just so you're aware. You'll see a lot of them talk about the nil control. That's the negative control. And so that's measuring how much background interferon gamma a person has in their serum just normally without the stimulation. The positive control is called the mitogen control. Basically, they expose the T cells to something called mitogen, which causes an interferon gamma release kind of regardless of anything. It's just a powerful stimulator. So it tests to see how well your body can produce interferon gamma. Because some people, if they don't have a very good immune system, might not be able to make interferon gamma, and therefore the test would not be accurate. So that's why it's the positive control. So again, issues with it is if you have severe immunosuppression, you could have a false negative because you have to have a good immune system for the test to work. The other issue, you should not use this test in kids under 2. Some providers do, especially if they've had the BCG vaccine, but it's not recommended routinely. In one of the state TB nursing courses, Dr. Kistner, who I'm sure a lot of you have heard of or heard her talk at the state conferences, in 2015, she gave a really good talk on how to interpret interferon gamma, a lot more about how the tests work. When you read the results, it has all these different numbers, the nils, the mitogens, everything. It's not a recording, it is her slide deck, but you can still get a lot of information from it. I put the link in here, we'll send you the slides, but also if you go into the state and kind of look around in their educational resources, you can find the slide deck as well. So again, a lot of good information there. So the skin test, again, the TST uses the PPD solution, which contains some other antigenic compounds or proteins that are mainly those secreted by the MTB complex, but it also contains a lot of other stuff. So it causes cross-reaction or matches with the BCG bacterium and other non-tuberculosis mycobacterium like Mycobacterium avium and a lot of other ones in the environment. So you can get a lot of false positives. Just like the blood test, if we have people that are really immunosuppressed, you can get false negatives. And people with positive skin tests, as well as IGRAs, but especially so with skin tests, that positive test can last forever. But like with our vaccines, you check someone's antibody titers years later, sometimes that has waned. Same thing here, that positive reaction can wane. So you could have had somebody who was exposed as a child and they might have a negative test when they're 50 or 60. So if you have someone who you're going to have to test year after year, like a healthcare worker, if you give them a skin test this year, it may be negative, but that exposure to the antigen may boost their immune response. So then next year it's going to be positive, but you might confuse that and think they've been exposed when really you just boosted their immune response. So that's the reasoning for the two-step. The first time a healthcare worker or anyone who may need repeated testing is given that two-step, is so that you don't think that their second test next year is from a new exposure. It was actually from the boosting. Hopefully that makes some sense. And then just a reminder with the skin test, there is not a one reading fits all. There's different measurements for different people. I know many of you have seen this before, where we have someone who's 5 millimeters or 10 millimeters, and they're sent to us saying they're positive, but they have absolutely no risk factors. So really, they should not be considered positive until they're 15 millimeters or above. And so that's a really common situation. So as we're interpreting skin tests, we have to really look at the different interpretations. And we have people sent to us where they measure them up and down the arm rather than across the arm, and many other things. So one thing, I think I may have taken it off this slide deck. If you ever do see someone who comes in positive with a skin test, and it was a few weeks ago, so you don't have the induration yourself to look at. If you have concerns about how the test was done, how it was read, you can always repeat it, because again, we never know if someone placed the test incorrectly or measured it incorrectly. So certain individuals should be screened for tuberculosis infection at least one time in their life. And then again, if they have one of these risk factors reoccur. And so that's people that have been born or stayed in a country for at least a month that had a high or medium incidence of tuberculosis. So that's basically if there's 10 per 100,000 incidents of tuberculosis or more. US has about 2.5 people per 100,000. Many screeners just basically say it's essentially any country other than the US, Canada, Australia, New Zealand, or any Western or Northern European country. Sorry, I moved this image and it covered up some of those words. What I placed here was an image and a link. The World Health Organization has a really nice TB report app, and it has every country listed, and it has kind of their TB incidence graphed out back to 2000. And that way, if you do have someone from a country and you want to see, gosh, was this a high incident country, a medium incident country? I'm not sure, especially with some of those European countries. You can really quickly and easily see where that country fell. So it's a free app. It's really nice. I downloaded it this weekend. So I just wanted to share that. So that's one of the indications to screen for TB infection. The second is if they were a close contact to someone with infectious TB at any point in their life. And then anyone who has immunosuppression, whether that's current or they plan to go on to immunosuppression at some point. So that's anyone with HIV infection, who's had an organ transplant, who's going on a TNF alpha antagonist, or who's on chronic steroid use or other immunosuppressant medication. So again, those individuals should be screened at least once, and then if that risk reoccurs. So if someone ends up traveling again for over a month to a high-risk country, they should be screened again. So that's just for routine screening. That's from the preventative task force group's recommendations. The state has a nice screening tool, just a one-pager for adults and for children that can be used for that. People are really under-screened, and so if you have providers or anyone who's looking to add screening into their practice, these are some nice tools that they can use. Now, if you have individuals who have tested positive and you're trying to decide if they're high risk or low risk, these are some additional things to consider. And I do have a algorithm that I've put together and that I'll share with you as well, so you can have that to use. So other people that are at higher risk that you may not necessarily always screen regularly, it just kind of depends on the epidemiology in your area. But if you were to see people with positive, people at higher risk would be people working in a mycobacterial laboratory, residents in homeless shelters, long-term care facilities, and correctional facilities. That's both residents and employees, and people who use illicit drugs. And then people with other medical conditions. The ones that I have in italics were the ones listed already as people who should be routinely screened, but other ones include lymphoma or leukemia, head and neck cancer, if they have been found to have some abnormalities on their chest x-rays, that could be signs of LTBI or old TB infection, silicosis, renal failure, diabetes is a big risk factor for those with TB infection for it to progress to active TB disease, people that are underweight, people that have decreased stomach acid issues because if they swallow TB, it doesn't get killed as easily. So that's where the intestinal bypass, gastrectomy, chronic malabsorption issues come in. Smokers, those are all risks for progression of infection, but alone are not reasons to screen somebody. People that have none of those risk factors, if you were to see them and they had a positive test, those are individuals that should have a second test because you worry they could have had a false positive. So you want to do a second test to confirm that they truly are positive. I'm not going to go much into healthcare, but there have been a lot of changes in healthcare screening. At this time, the risk for most healthcare workers is extremely low, and so you do test someone on higher who's not already had a documented infection. If they have no risk factors, so like if they've not been working in a long-term care facility or, they're not from another country, you'd consider them low risk, and so they should have a second test to confirm that positive test. If they are confirmed to be positive or they've already been diagnosed with LTBI, it's really encouraged that they get treated. There's no recommendation to do serial testing, so no recommendation to do yearly TB testing anymore. People who refused treatment should have annual symptom screening, and then just yearly we should educate healthcare providers about TB, which on our SharePoint, there's an education link there for all of us to look at. So this algorithm is something I've been tweaking over the years, and so I'll share this again, but it basically should walk through most situations. As a note, talks about screening only being recommended for those situations where someone lived or had temporary residence in a high-risk country, immunosuppression, or had exposure to active TB. This is kind of addressing anybody who's coming to see us for evaluation, not necessarily whether or not they need screening. So if we see somebody first we want to say, okay, are they at risk for infection? And we're assuming that they're over 2 years of age and they don't have any symptoms of TB. So we're also going to assume this takes into account which tests to do. So if we do need to test somebody as well, I'm trying to give you a resource where it helps you to figure out all those different decisions. So if the risks for infections are listed here in the red box, so contacts to active disease, the mycobacterial personnel, living in the high-risk countries, high-risk congregate settings, and then illicit drug use are the risks for infection. So you're either high risk for infection or low risk for infection. And then the risk for disease progression, which I have listed here, that's the different immunocompromising conditions, diabetes, cigarette smoking, abnormal chest x-rays, things like that. So then if for each risk level of infection, you can go through to the risk level of disease progression. And then this one takes into account BCG infection, BCG vaccination. So it talks about which tests are preferred or which tests are acceptable. Here you'll see where you have no risks for infection, no risks for disease progression. This group is not recommended you test them. However, we often have to because of their workplace or school or some other requirement. This goes down and says, IGRA is recommended, skin test is acceptable. If it's positive, perform a second test. If it's positive, then you would go to the LTBI evaluation. If it's negative, then you would rescreen them only if a new risk factor for infection or other indication occurred. So that's kind of how that worked. Here, if you'll notice, let's say this is kind of the worst case scenario, high risk for infection, high risk for progression of disease. If we ended up at negative, if they're immunocompromised, you want to consider the possibility of a false negative. So these are people who may need a second test just to rule that out. That's more of a clinical decision, but I just wanted to point that out that that's there too. So hopefully this can help you to walk through different decisions for different situations. Again, I'll get this in a hard copy to you or in a file. It's 2 pages, but just to kind of walk through that. This I put in here just to help you with BCG vaccination. You can go to a website here called bcgatlas.org, and you can see what countries routinely do vaccinate. Also, anyone who's had a BCG vaccine should have a scar on their upper arm, and it typically bumps out like this one here on the top. The smallpox scar is more of an innie, and the BCG scar is more of an outie. Some are really quite large. It causes a lot of inflammation at the time of vaccination. So just so you're aware, I did want to point out here on this algorithm that if someone did have a BCG, the IGRA is the preferred test, but if someone did already have the skin test and it was positive, they're coming to us with that, you can call me and we can decide, based on whether or not they've had other risk factors, whether or not we should do an IGRA. Obviously if they had a BCG vaccine, they're coming from a high-risk country. However, some people came to the U.S. when they were really, really young, and therefore their risks are quite low. So again, those are things we can talk about and decide if the risks of a false positive skin test are there and we should do a second test or not. So now we've gone through all of that and hopefully gotten to a point where we've decided, yes, we have a positive IGRA or a positive skin test. We're confident that it's a true positive. And so this person is infected with TB. We have to decide, is this LTBI or is this active TB? what you'll want to do is then see if they have any symptoms, which are typically a cough that has been lasting for greater than 2 weeks. It's usually productive. They usually have bloody sputum, can be short of breath, fever, chills, night sweats, weight loss, tired, and they're usually quite sick. Some people have extrapulmonary infection, and so it can be in the larynx, it can be in the bones, it can rarely be in the meninges or in the brain, it can be in the pelvis. So that's why those other symptoms are there, to try to pick that up. We ideally want these individuals to have a physical exam. That's one issue that with the way that we do LTBI, I'm not able to do physical exams on everybody. So as best as you feel able, at a minimum, just try to make sure they don't have big swollen glands around their neck. If they have any physical complaints, they really do need to see a physician or a physician extender, so we can work on setting that up somehow. You want to go through their medical history. We really need to know all their medications, especially contraceptions, any opioid use, medication-assisted therapy, because some of the medications really do interact with those. Any of those risks for developing active TB, risks of exposures, and any previous treatment they may have gotten for TB or LTBI, and as specific of details as you can get. If you can get any documentation of prior treatment, that is ideal. If they've been treated previous for LTBI and we can get some pretty confident history or records of that, they won't need to be treated again. Otherwise, we might have to. I've put together a new form that you can go through with patients. It follows the MDSS detailed form for the most part. It has in there, though, the things that MDSS does not have that I really need to know in order to treat them. So it does have, again, what's in MDSS, but it has their symptoms, it has the risk factors for progression, it has a list for their medication, and then it has here, just as a reminder, the interpretation of a skin test, just in case you need that. I do have it as a fillable PDF, so all these fields are fillable. So you can either just fill it right on your computer and then save it and upload it to the notes section, or you can print it off and do it by hand, write in it and then scan it and upload it, whichever you prefer. So I just wanted to show this to you, and then we'll send it out so that you have it available. If you have anyone with symptoms, if you have a child, if you have someone who's pregnant, if you have someone who was recently exposed to an active case, if they have physical abnormalities, or you have any questions at all, just call me and we'll work through it. Otherwise, once you've gone through this, you have no concerns about anything unusual, you can place orders. You can order a 2-view chest x-ray. If they've had one within 3 months, it's typically acceptable. When you get it, just make sure and read the full report. I don't see this too much anymore, but every once in a while it'll say normal chest x-ray in the assessment, but then up in the text it'll say something about scarring or other things. So it's just good to read through the whole thing. Every patient who has TB infection, not just active TB, but every patient with TB infection should be offered HIV testing, should really be encouraged to get HIV testing, because that is a really big risk factor for progression. They may need liver function testing, and I'll talk about that here in a second. As a side note, if for any reason there is some suspicion that they could potentially have active TB, and really anyone with symptoms, any significant abnormality on their chest x-ray, we will want to get sputums. We cannot start any treatment for LTBI until the cultures are final, which can take about 6 weeks. If you start treatment before you know for sure, you could lead to drug resistance issues. If you started them on 1 or 2 drugs and then at week 5 you found out, oops, they have active TB, that's just something you don't want to happen. So just as an FYI, it doesn't happen often, but just so you're aware. So the ALT is really the only test we'll do as screening unless someone does have elevated tests or there's a problem. Just as a note, the ALT is the most specific indicator for hepatocellular injury. That's why it's the only one we check. It's just more cost effective. Again, unless there are problems. The medications we use can all be hepatotoxic. INH is the most likely to do that. So we do have a policy about this. Anyone who has significant alcohol consumption, which I did put a definition of that there, just so you had some indicators. Anyone who has hepatitis, if they're pregnant or postpartum, injection drug users, people who have had problems with INH before, any kind of liver disease, HIV. They found that people who are over 35 are just more likely to have problems. It's still really rare, and I've really not seen it happening, but that's just what studies have shown. It's really a bigger issue for people over 50 or 60. But I have made sure to follow people who are over 35 just to be safe. And then people who are on a lot of meds or have chronic issues, I kind of decide on a case-by-case basis. If people don't have risk factors, we don't need to follow their LFTs. We used to only offer the 9-month treatment, so the monitoring was at baseline and then 1, 3, and 6 months. Now we're offering some shorter treatments, so I usually just give recommendations at the start of treatment. So we'll talk about that here in a second. So if you then, I know it's a lot of stuff, it sounds really complicated, but it really isn't too bad to get through all of this. If you do then have a patient with a positive test for TB infection and they don't have any symptoms of active TB and their chest x-ray is normal, sometimes they'll have a little granuloma or some scarring. That is not uncommon with LTBI. And if they happen to have had to have gotten any sputum and that was all negative, so if all that's normal, you've basically ruled out active TB disease and LTBI is then diagnosed. So we need to then consider them for treatment. And at that point, you want to upload everything into MDSS, including that assessment form that I showed you. And just shoot me an email with their MDSS number and I will review everything. And then I will send recommendations of what treatment they should have. So these are our main treatment options now. And thanks to our wonderful management, we do have all of these available to us now. Again, we used to mainly just give 9 months of INH. There were risks of liver irritation and just not really good compliance because it was every day for 9 months. The guidelines recommend shorter therapy because it's better complied. The first recommendation is isoniazid and rifampicin, which only comes as a brand name right now. It's called Priftin. It's once a week for 3 months or 12 weeks. It is the lowest total pill burden, but once a week they do take quite a number of pills. So that's just something to let them know. But again, overall, it's the least number of pills overall. It used to be we could only give this to people by what we call DOT or directly observed therapy. But if you screen them and you feel they are reliable and they're not going to forget to take it once a week, doing what they call SAT or self-observed therapy or self-administered therapy, people are just as compliant as with directly observed therapy. Again, if you have concerns about someone taking it, you can always do video, directly observed therapy through video or other methods like that. If there's some reason as a contraindication or you have concerns about compliance with that, the second option is rifampin. It's daily for 4 months. And if there's issues with either of those, which rifampin and Priftin both have a lot of drug interactions, the third choice is isoniazid for 6 months. 9 months is likely more effective. So if someone is being really compliant, we can push it out 9 months, but it appears that 6 months should work just as well. So that is kind of the go-to now, is 6 months. So this gives kind of the pros and cons of all three of these. So again, for the rifampicin isoniazid once a week, it's less likely to irritate the liver, it's better compliance, fewer number of dose or pills. It does cost more, it has a lot of drug interactions. Very rarely people can be lightheaded or even pass out, but that's really, really rare. It's not recommended in kids under 2 or for those who are pregnant. For the 4-month rifampicin, it's pretty similar benefits and pretty similar disadvantages. And the 6-month INH, it's really cheap. It has less drug interactions, but it is more likely to irritate the liver, and it's a longer treatment course. So the main side effects with the INH, again, it can increase your liver function test, which is not harmful, and it does get better, and I'll talk about that in a second. But it can cause actual hepatitis. It's rare, but can be serious. It can cause peripheral neuropathy, which we counteract, and I'll talk about that in a second. Some people do get a rash, just like a macular, papular, or fine red rash, which is harmless and tends to go away, but it can happen. Extremely unlikely, uncommon. It can irritate the optic nerve. Some people get achy joints, which is usually self-limited, and it does go away once treatment is ended. The other issues of CNS changes, drug-induced lupus and diarrhea are extremely rare. Rifampin, again, rifampin or rifampicin have very similar side effects, lots of drug interactions. They can both stain body fluids like tears, urine, breast milk, orange, and that stains things like contacts, undergarments, things like that. These can both also cause a harmless rash, upset the stomach. Rifampicin, when it's taken, or rifampin, I'm sorry, if it's taken on an intermittent basis, which there are some dosing regimens which are not as proven that do that, can cause like a flu-like syndrome, but I've never had issues with that. Much less likely to cause hepatotoxicity, and very rarely can it cause some changes in blood counts, but monitoring of the blood levels are not required. With INH, again, between 10 to 20% can have elevation of the LFTs like the ALT and the AST that will go back to normal when the medication is stopped. We don't stop the med unless the person has levels that go above 5 times the upper limit of normal with no symptoms. If they do have any symptoms like right upper quadrant pain or nausea or things like that, we stop the medication if it goes 3 times above the upper limits of normal. I have had a couple where it has gone quite high, and it completely resolves when they're off the medication. Very rarely do people actually get hepatitis. It's more in people who are over 50. Knock on wood, I've not had this issue before. There are extremely rare cases where people have died from this, and that's the reasoning for careful monitoring of the ALT, counseling people to avoid alcohol, trying to avoid it if people are alcohol users. Peripheral neuropathy is very rare. It mainly happens in people with diabetes, renal failure, HIV, alcoholism, and pregnancy. Vitamin B6 can help prevent it and is really only recommended in those that are at high risk for peripheral neuropathy, but we do give it to everybody who's on it just to be safe. We give 50 milligrams per day while people are on INH, or 50 milligrams per weekly dose. As a note, if you give more than 100 milligrams per day, it could actually cause some nerve damage. So this is one where more is not necessarily better. So the rifampicin and the rifampin, again, it can cause the orange staining. The hepatotoxicity is much less. Self-limiting harmless rash can occur. rarely can you have other hypersensitivity reactions. Again, it can decrease the efficacy of hormonal contraception. That's why I'm always asking if they're on birth control. We can't use it if people are on methadone or other opioids. I did put a link to a good free drug interaction checker just in case you're interested. Once I get their med list, I always check drug interactions on Lexicon, which is a paid resource through UpToDate, so you don't have to worry about that. But again, if you're just curious and want to check, that is a good reference that's available. And then once their treatment's been decided upon, you just want to make sure they're well educated. Make sure they know that for most people, there's about a 10% risk they will get active TB disease by the time they're 80 if they don't take all their medication. We get a lot of people that panic when they find out that their family members have TB, just to make sure they realize that they're infected with a sleeping form of TB, but they're not contagious, and so that they're not going to cause any worry. Some people have a big stigma about TB, so just to be aware of that. Need to finish all their medication, all the side effects, and that they need to let us know so that we can help them out with them. They need to avoid or limit alcohol, they need to take their B6, and the need to keep their treatment completion letter for life, how important that is, and that it's rare, but it is possible for them to still have active TB in the future, and they need to report any symptoms if they develop. You will see them or follow up with them at least monthly. If they're having any side effects, you do want to make sure to see them face to face. If people are doing really well and you're not worried about their compliance, it is acceptable to see them by phone or video or other method, especially, if we're having issues with COVID or other types of problems. This is very busy, but this was just a copy and paste I made of one monitoring form. When you do talk with patients monthly, you just want to talk with them and monitor them for any of the possible side effects that may occur with their medication, depending on what medication they're on. I know that was a huge whirlwind of material. I know, again, some of you are much more experienced with LTBI than others. So I will open it up to questions at this point if anybody has any.
Dr. Morris, if that last slide that you showed with the symptoms, if a client has any of those, is the expectation just reach out to you and have a discussion about what's going on?
Yeah, typically that is the best thing to do. I meant to mention, I am putting together a guide that covers pretty much all of the most commonly used meds that we use for both active TB and LTBI, and the most common side effects and things that you can do about them. Not that it's going to supersede, calling me and talking through it, but most of it comes from the Curry Institute for TB. I think that's the name of it. One of those TB Centers for Excellence has a book on multi-drug resistant TB, and they have some really great resources on the medications, and they had great information on handling side effects. So I'm trying to put together the parts of that that's most useful to us, because we don't use a lot of those drugs frequently, the ones for multi-drug resistant TB. So I almost have it done, so I'm hoping to get that done pretty quickly, because some of those tips are really helpful. For those of you who have worked with TB quite a bit, things like nausea or upset stomach or things are really common, and so to have some go-tos would be a really nice thing to do. But again, I think the main take home is if you ever have questions, concerns, anything, don't hesitate to call me or email me. I'm more than happy to bounce off ideas, or just make sure. We all have those times where we just want to make sure we're on the right track. I'm more than happy to help out with that. The other thing, if you've not seen it before, if you go to, I don't know how many of you went to the, well, I shouldn't say went to, called into the state TB conference this year. If you go to michigan.gov/TB, there is a lot of good information there. It's a little tricky to find things, but if you go to that page, there's a tab that says training and education. And there's two tabs. There's educational events, and there is the TB Nurse Network. So both of those tabs have a lot of old webinars that have a lot of good information. But again, it is just a kind of a process of going through and clicking and reading. So if you have time someday and want to click through, you can find some old useful information there too.
I just want to say thank you, Dr. Morse.
Yes, thank you very
No
much.
problem. And I'll get the slides and that algorithm and the questionnaire, the LTB intake questionnaire to Annette to get out to everybody. I think that's probably, the most efficient way to do it? I'm not sure, but.
Yeah, and then this will also be, since it's being recorded, it will be attached to a link, and they can always review this information you shared, Dr. Morris.
Okay, and then I'll keep working on that medication handout. Hopefully I'll get that done within the next few days, so.
Awesome. All right, I'm going to stop the recording. And again, thank you very much.
All right, thanks, guys. Sorry.